Thank you, everyone. All right. Hello, my name is Dr. Diana Feldstein, and I'm one of the MAVEN physician volunteers. Thank you for joining us for our talk today, and for our friends who are anchoring this clinic to host today's session. We are going to talk about the updated guidelines for management of hyperlipidemia with Dr. Sadur, and that's Sadur. Dr. Craig Sadur it was an professor of medicine at the University of Colorado Health Sciences Center and the chief endocrine unit at Denver General Hospital. After 9 years of private practice in endocrinology, he joined Kaiser Permanente in Northern California, where he practiced clinical endocrinology for over 24 years and received the Career of Caring Award for exemplary physician. All right, and then with that, I'm gonna just show the disclosure slides for MAVEN, as this is a CME talk. So I just want to disclose that we have nothing to disclose for this educational activity. One more thing. And then we are accredited, as I mentioned, and you will get a maximum of 1 credits. You should claim the credit only commensurate with your engagement with today's talk. All right, and with that, I'm going to stop sharing and give it over to you, Dr. Sadur.
Yay. All right. Okay. Thank you so much, Dr. Feldstein, and thanks for everyone for being here. Good afternoon. And as mentioned, we were going to go over dyslipidemia. So it's the cholesterol management guidelines, which came out not too many years ago, but there's been a lot of activity since then, and that's why we're updating it repeatedly. So with that, the guidelines came from the American Heart Association in collaboration with the American College of Cardiology. And subsequent to that, the Endocrine Society came out with their own guidelines in terms of dyslipidemia management in patients with specific populations. So the agenda today, go over cases and to review the non-pharmacological measures and to look at risk stratification of different patient populations. As we see, one size won't fit all. There's an online risk calculator that helps us decide if certain patients need treatment, hone in on some special populations of patients in terms of their lipid management, drug therapy for individualized treatment, and then end it with information resources that can be helpful for you. Let's dive into the cases. So case number 1, a 20-year-old healthy Caucasian female, no history of diabetes mellitus, hypertension, dyslipidemia, tobacco use, or any family history of atherosclerotic cardiovascular disease. On exam, her weight's normal, her vital signs are normal, unremarkable exam, sort of the ideal patient that we would see. So is there anything we need to do? Well, with this, it is worth counseling her regarding her benefit with lifelong healthy lifestyle. That would be good nutrition, weight control, keeping her weight in normal range, exercise, stay tobacco-free, and stress management. And measure the lipid panel, ideally fasting, because you can get more accurate triglyceride reading. But if she can't or won't do a fasting panel, go ahead with the non-fasting. You'll be getting a lot of information regardless. So here's just one of the many places in terms of education of lifestyle. The American Diabetes Association has a food hub that's available for patients. Don't have to be diabetic, but can get some good ideas on practical nutrition. The American Heart Association has a Move More Together patient education on exercise. Nationally, the goal is to do 30 minutes of exercise, ideally every day of the week, at least 5 days a week. And that's been shown to be beneficial on so many levels. And then smoke cessation, the National Institute of Health has a National Library of Medicine, has a nice section on smoke cessation that patients can tap into. And in terms of stress management, just to pick one, this was Dr. Benson, cardiologist. And what he did, I think it was back in 1975, published his work in the relaxation response. That's very readable for patients. And it really helped be a landmark work in terms of stress management and the benefits to our health. Okay, let's do case number 2. We have another young patient. We have a 25-year-old Asian male. So he has an increased abdominal girth. And his blood pressure 130/85, his fasting blood glucose 101, his HDL cholesterol 39, his triglycerides 151. So at quick glance, you look at the blood pressure, you look at the labs, and you go, not bad. So what do we do with this young gentleman? Well, again, lifelong healthy lifestyle is the cornerstone of treatment. And start to assess him, even though he's young, start to assess him by age 20 years. And we're thinking of primary prevention of atherosclerotic cardiovascular disease. It looks like he's got metabolic syndrome, and let's look at that. So the classic adipose distribution, if it's mainly abdominal, that's been called built like an apple or android because it tends to be more often in men, but we can see it in women, versus the pear configuration or gynecoid tends to be more common in women, but it can be in men. It turns out the abdominal adiposity has increased atherogenesis, and this young fellow had an increased abdominal girth. Now, we don't know the measurements, but right away we're concerned about it. And with the metabolic syndrome, it takes 3 or more of the following criteria. Waist size, at least 40 inches in men and 35 inches in women. And it was the not too distant past where it was shown with Asian patients, like our patient, to look at numbers different than the other ethnic groups. And that would be at least 35 inches waist circumference in men, 31 inches in women. So that would be one of the criteria for metabolic syndrome. Triglyceride at least 150. He met it on that level. HDL less than 40 in men, less than 50 in women. His was under 40. Blood pressure at least 130/85. His was 130/85. And right away, we've got the 3 criteria and maybe the 4th, because we don't have his weight measure, his circumference of his waist measured. And then lastly, blood glucose fasting, at least 100, and he did have that. So he has metabolic syndrome, and young and seemingly healthy, but we're concerned that he is at higher risk in the future. Okay, case number 3. We've got a 50-year-old Latina female. Now, certain ethnic groups, Latinos are one of them in terms of a propensity for metabolic disease, such as obesity, type 2 diabetes, hypertension, dyslipidemia, and unfortunately, a propensity for atherosclerotic cardiovascular disease. And lo and behold, she's had a myocardial infarction, and she's had a history of a cerebrovascular accident. So right away, at her young age, we're very concerned. We're talking about secondary prevention of atherosclerotic cardiovascular disease. So you get your labs, and her LDL cholesterol is 90, and you look at that, and the first thought is, that looks pretty good. So what do we do for this patient? What can we do to help her? Well, lifelong healthy lifestyle. We don't know information about tobacco and exercise and nutrition and such, but if she's doing well with it, we want to encourage her to continue. If there's things that need improvement, help direct her. Eliminate, when possible, or at least reduce risk factors for atherosclerotic cardiovascular disease. And she's got significant disease. She has coronary artery disease, cerebral vascular disease. And so we're talking about a statin for her very high-risk atherosclerotic cardiovascular disease. And she may need, many patients may need an addition of a non-statin treatment to go along with their statin. And the one that's been around for decades now is ezetimibe. And for her, consider an LDL goal of under 70. And the goal, as we've seen over the years, has gone lower and lower and lower. So in someone with known atherosclerotic cardiovascular disease, you want to get her LDL below 70. So that first glance of the LDL of 90, it's too high in her. If you had someone else who had absolutely nothing going on, that could be fine, but not in her. The data is so good that reducing LDL lowers the risk of complications in the future. And just like with the trend, we're going lower and lower. Consider an LDL of under 50 if she's had acute coronary syndrome in the past year, if she's got family history of atherosclerotic cardiovascular disease, if she has diabetes, type 1 or type 2, chronic kidney disease stage 3 or 4, so really not dramatic. We have lots of people with these levels. If she's had a repeat atherosclerotic cardiovascular disease event, which she's had myocardial infarction, and then she had cerebrovascular accident, or if there was ever a need for revascularization. So she definitely needs statin. High intensity statin is certainly something to consider, and an LDL goal of under 50 again puts her in a better position to have an improved future outcome. So LDL cholesterol in clinical atherosclerotic cardiovascular disease, as this woman has, lower LDL with high-intensity statins, or at least maximally tolerated statins, to lower that risk. It's been shown over and over. The statins have been around for decades, and the data has repeatedly, with different groups being studied, show benefit. And atherosclerotic cardiovascular disease has a wide net. She has her cerebrovascular accident, she has her coronary artery disease, but it can also be for patients with transient ischemic accidents, acute coronary syndrome, any arterial revascularization needs, peripheral arterial disease, aortic aneurysm. So these are patients to consider treating sooner rather than later. So we talked about the high intensity statin. Let's focus on that. So the high intensity statin is designed to lower the LDL cholesterol by 50% or more. And the two that fit that are on the market available are atorvastatin 40 to 80 milligrams once daily, or rosuvastatin 20 to 40 milligrams daily. The moderate intensity statins lower LDL by almost as much, 30 to 49%. Atorvastatin 10 to 20 milligrams, rosuvastatin 5 to 10 milligrams, simvastatin 20 to 40 milligrams, lovastatin 40 milligrams, and those are all once daily, usually in the evening. But fluvastatin, if you give it, is 40 milligrams BID. And the low intensity to lower the LDL by under 30% would be pravastatin 10 to 20 milligrams or lovastatin 20 milligrams. This might be a consideration. Let's say you had a patient who was a surprise. You have concerns, you want to get the LDL down, but the LDL is already 50. It doesn't mean you do nothing. It's still worth giving a statin, but in that small minority case, you can give a low intensity statins, and there's lipid lowering qualities and maybe endothelial stabilization of the vasculature. So statins have been the cornerstone of pharmacologic treatment. And one word on statins in terms of CYP3A4 inhibitors, which many patients may need. So the cytochrome P450, 3A4, the CYP3A4 inhibitors, such as diltiazem, when you take it with statins, and the statins in particular, simvastatin, lovastatin, and to a lesser extent, atorvastatin, those are metabolized by the 3A4 system. So if you're taking a medicine that inhibits it, these medicines are less metabolized, which increases the myopathy risk. It doesn't mean they're contraindicated when patients are on 3A4 inhibitors, but it's just something to keep in mind. Rosuvastatin is metabolized by a different pathway, the cytochrome P450 2C9, and the classic 3A4 has only a minor role. So if you have patients on one or more 3A4 inhibitors, maybe rosuvastatin, all other things being equal, could be the choice. Okay, so we talked about non-statin medicines in terms of ezetimibe. So statins are the cornerstone of pharmacologic therapy. They're almost always well tolerated. They almost always, for a given patient, bring that patient down to LDL goal, but there are a significant minority that it's not enough. So fortunately, there's other medicines in the armamentarium. So the ezetimibe, like I said, been around for years, very well tolerated, and goes fine with statins. There's bile acid sequestrants that have been around even longer in the pre-statin era. Um, they can cause GI symptoms, some abdominal bloating, constipation. You have to be aware of concurrent medications such as warfarin or L-thyroxine in terms of timing the bile acid sequestrants with that. But they work, and there's some very old data that show that they lower the risk of coronary artery disease, and they're very inexpensive. Then there's bempedoic acid that came out recently in a New England Journal article as an alternative for patients who, for whatever reason, may not be able to handle statins, and they have good outcomes, but they are expensive at this point. Inclisiran, again, effective, expensive. And the one that really brings the LDL down quite a bit is the PCSK9 inhibitors, which are also expensive. So most patients, fortunately, don't need to go to these levels, but they are there and things can be done. In terms of insurance, usually reaching out to the insurer, and a lot of times with Medicaid and other insurers, when you've documented that you've been through everything else, a lot of times they have been approved. Okay, this is regarding secondary prevention, which Lisa Tannick of Endocrine Society put together beautifully. So if you have a patient 75 years or younger and has clinical atherosclerotic cardiovascular disease, like this patient we had, the 50-year-old woman who had the myocardial infarction, the cerebrovascular accident, high-intensity statin is really the way to go. And if you have a patient with known disease at very high risk and an LDL 70 or higher, despite maximally tolerated statin, add ezetimibe, and that may be all you need. It often is. But there also are the other alternatives, such as the PCSK9 inhibitors. They are expensive. But again, if you've exhausted every other way and you're trying to get the patient on the best regimen, insurers have been able to often provide that. If you have a patient over 75 with atherosclerotic cardiovascular disease, consider initiating or continuing moderate or high-intensity statin. A lot of this, and you've seen this in clinic, this is a clinical judgment. There are plenty older patients who are physiologically doing well and mentally sharp and have an interest and want to have treatment so that they can go on and enjoy life. And that would be in contrast to a patient who has severe dementia and a very low life expectancy. You're not going to be as intense, but it's clinical judgment. A lot of people do well with treatment. And the 2023 American Diabetes Association guidelines were also repeated in 2024 with their updated guidelines, recommend patients with known atherosclerotic cardiovascular disease who have diabetes to get that LDL below 55. So diabetes and known disease, be very aggressive. Okay, case number 4, 30-year-old Pacific Islander male. Now, ethnic groups like the Latino patient, Pacific Islanders do have an increased incidence of metabolic abnormalities that can lead to atherosclerotic cardiovascular disease. This patient's father had a myocardial infarction, uncle, maternal uncle, history of angina. So he's got the double whammy. He's got atherosclerotic cardiovascular disease on both sides of his family. And he's got an LDL of 190. So with that, what do? We're talking to him about his diet history and medication, but you also, with his level of hypercholesterolemia, wonder if there's something else going on. So screen for hypothyroidism with a TSH, check for nephrosis. You could do a urine dipstick looking at protein, and check for cholestatic liver disease. And a lifelong healthy lifestyle is important. You want to eliminate or reduce risk factors when possible. High intensity statin. He's got a LDL of 190. It's going to take a lot to get him down. So just go to the high intensity. And you're shooting for an LDL goal of less than 100. And it wouldn't be a surprise if you have to add a non-statin medicine like ezetimibe. So severe primary hypercholesterolemia, that's what this patient has. It's defined as an LDL of 190 or higher. It's common in genetics with heterozygous familial hypercholesterolemia. So a lot of times relatives have it but don't even know it. So if they can have their fasting lipids checked, that'd be helpful. This is the number that always makes me stop. It's a 20-fold greater increase cardiovascular event risk to have an LDL of 190 than if his LDL was 130. LDL 130, 1/20th the risk than if he stays with an LDL of 190. So there's a lot we can do to help him. So treat with statin. The primary goal is to decrease it by at least 50%. Secondary goal is to get that LDL level below 100. And if it's still above 100, consider adding ezetimibe. Case number 5, 40-year-old Black female. Blacks as well as Latinos and Pacific Islanders have ethnic genetics propensity for developing metabolic abnormalities that lead to atherosclerotic cardiovascular disease. She does have type 2 diabetes, but for her, there's no family history of atherosclerotic cardiovascular disease. She's not a smoker. She has normal blood pressure. Her weight is normal. Her exam's unremarkable. So what do we do? Lifestyle. Keep monitoring those risk factors. Hopefully she'll remain normotensive. Hopefully she'll remain a non-smoker, etc. Optimize diabetes control. You know, the old studies have shown even with type 2 diabetes, you get their levels down and you can get some macrovascular benefit. Checking lipids, preferably fasting. And if the LDL is 70 or higher, give a moderate intensity statin treatment for primary prevention. We don't want her to have her first event. And when you give moderate intensity, you're going to measure and see if that's enough, but at least that's a place to start. So the satanic, again, very helpful, brought up the point of women and pregnancy. And our patient is 40 years of age. We don't know anything about her menstrual history, her pregnancy possibility, pregnancy desire, but it's something to consider when you're treating a patient of reproductive age. Statin should be discontinued 1 to 2 months prior to a pregnancy attempt, but discontinue the statin as soon as a pregnancy is discovered, if patient's already on it. And women of reproductive age on statin should be counseled regarding reliable contraceptives, oral contraceptives, or IUDs because of the potential teratogenetic effects of statin. Case number 6. Okay, 60-year-old Black male with type 2 diabetes, but unlike the patient before, he's got multiple risk factors. He's a smoker, he's hypertensive, he's got family history of atherosclerotic cardiovascular disease. His weight's normal, his exam's unremarkable. What do we do? Lifestyle. Tobacco cessation, very important. Hypertension control, very important. Optimizes diabetes. And check his lipids, preferably fasting, and consider a high-intensity statin. He's got multiple risk factors. I mean, sort of start aggressive early. Now, for both of these patients, they have diabetes, and they're between ages 40 and 75. So if the LDL 70 or higher, give a moderate intensity statin at the very least, but you're going to remeasure to see how effective it is. The moderate intensity statin, just a reminder, lovastatin 40, pravastatin 40, simvastatin 40, atorvastatin 10 to 20, rosuvastatin 5 to 10. And if there's diabetes and multiple risk factors, which he has, or age 50 to 75, which he is, it'd be reasonable to just go right to the high intensity statin to cut that LDL by at least 50%. So the LDL goals, if you have a patient with diabetes and atherosclerotic cardiovascular disease, high intensity statin to decrease that LDL by at least 50% from baseline. Shoot for an LDL goal of less than 55. You know, it's a big concern. There's a lot of things going, and secondary prevention is key because the patient's at such high risk. And adding ezetimibe, PCSK9 inhibitor, or inclisiran would be recommended if the goal is not met on the maximally tolerated statin treatment. So just to stay on top of it. Now, special populations. For type 2 diabetes and diabetic retinopathy, we're talking like maybe just background retinopathy, like so many people have. Consider fibrates in addition to statins to reduce retinopathy progression, regardless of the triglyceride level. So we're all used to giving fibrates for hypertriglyceridemia, but here the caveat is the outcome is improved with fibrates, even with normal triglyceride levels for patients who have known retinopathy. And if you're going to give a fibrate on top of a statin, then the fibrate of choice is fenofibrate. Now, with type 1 diabetes and statin, it's a consideration irrespective of the cardiovascular risk score. If you have a patient who's 40 years or older, patient who's had diabetes for over 20 years, let's say 8-year-old gets it, and by late 20s, we're concerned about the cascade of possible complications occurring. Microvascular complications, this is, again, could be background retinopathy, something that looks relatively mild, or nephropathy with albuminuria, obesity, especially, while you're trying to intensify insulin to get the sugars under control. High triglycerides and low HDL cholesterol, that's a very atherogenic lipoprotein combination with a small, denser, more atherogenic lipoproteins. And so if you have a type 1 patient with any or more than one of these, really consider statin treatment. And again, it's trying to prevent future problems. Type 1 diabetes and chronic kidney disease with stages 1 through 4, mild disease, again, being part of that, consider a statin irrespective of the cardiovascular risk score to reduce the cardiovascular risk. And the thinking is that chronic kidney disease in some ways is a proxy for underlying atherosclerotic cardiovascular disease. So we're looking for a signal to go, there could be something going on underneath, so treat. So with type 1 diabetes, consider a statin if LDL is greater than 70. When selecting a statin, you may need to look at renal clearance. Pitavastatin, pravastatin, rosuvastatin to have some clearance through the kidney, whereas atorvastatin, fluvastatin, lovastatin, and simvastatin are cleared by the liver, an advantage. All statins require dose adjustments in chronic kidney disease, except atorvastatin and fluvastatin, so you don't have to make changes with that. Ezetimibe can be added to a statin to lower the LDL further, and you don't have to do adjustments in chronic kidney disease. Okay, case number 7. 50-year-old Native American female. In Native Americans, indigenous population, similar to Latinos, similar to Pacific Islanders, similar to Black patients, do have increased propensity to have atherosclerotic cardiovascular disease. This patient, fortunately, has no family history of atherosclerotic cardiovascular disease, not a smoker, normal blood pressure, no diabetes, no history of dyslipidemia, but no testing for years. So we don't know. It's like we don't know what we don't know. So what do we do? Lifestyle, important. Continue to monitor for risk factors. Check the lipids to see if the LDL is 70 or higher. And then you can do a calculation on the 10-year atherosclerotic cardiovascular disease calculator, see if the risk is 7.5% or higher, meaning in the next 10 years, the chance of a cardiac event or a cardiovascular event being 7.5% or higher. Then you can make the case for considering a moderate intensity statin treatment. And here's the calculator. You've seen this one comes from the American College of Cardiology. There's various other places you can get on the internet for free. Easy to fill out. Current age, gender, male, female, race. Now, right now, it's limited to whites, blacks, and others, but hopefully at some point we'll have other ethnic groups, but that's what we have now. Blood pressure, systolic, diastolic, cholesterol, total, HDL, LDL. Now you notice they don't have triglycerides, so you could do a non-fasting test and get the lipid panel components that you could put in here. The only problem is there are patients with significant hypertriglyceridemia, and in that case, many labs will say the LDL could not be reported because it's a calculated value. Now, some labs will go ahead and do a direct measurement, but the fasting test will give you most likely the benefit. History of diabetes, yes, no. Smoker, current, former, never. On hypertensive treatment, yes, no. Statin, yes, no. Aspirin, yes, no. So easy to fill out, and you can find out if they have a 10-year risk of 7.5% or higher. So if you have a patient, age 40 to 75 without diabetes, it's a shared discussion. You're talking to the patient about risks and benefits. And review the risk factors: smoking, hypertensive, dyslipidemia, A1C, and the calculated 10-year risk. And the tool is there, and a lot of times patients can see it and they go, oh my gosh, there is a relatively high risk, and they may be more motivated for treatment at that point. And if the risk is 7.5% or higher, it's worth them considering statin treatment. And if they're open to it, that would be the recommendation. Case number 8, 52-year-old Indian male, no family history of atherosclerotic cardiovascular disease. He has psoriasis. Estimated glomerular filtration rate is down, and it's 50. Okay, so what do you do? Well, lifelong healthy lifestyle. Continue monitoring risk factor, check the lipids, preferably fasting, and do the calculation for the 10-year atherosclerotic cardiovascular risk. If it's 7.5% or higher, consider statin. But with him, there's some added features. There's something that the American Heart Association, American College of Cardiology are putting out as atherosclerotic cardiovascular disease risk-enhancing factors. And if there's a family history of premature atherosclerotic cardiovascular disease, like that lady we had, no, it was one of the gentlemen. He had myocardial infarction, father, and he had a maternal uncle with a cerebrovascular accident. So you just get this gestalt. This patient has genetics that are concerning because of premature vascular disease. If you have an LDL that's persistently 160 or higher, so not in that 190 familial hypercholesterolemia range, but 160 or higher, they're just sort of in this lipid milieu that could be laying down lipids in the vasculature. Metabolic syndrome, we saw that in our early patient. Chronic kidney disease, we know that patients with chronic kidney disease have increased cardiovascular risk. For a woman, history of preeclampsia or premature menopause, that's arbitrarily defined as occurring before the age of 40 years. So these are risk-enhancing factors. Chronic inflammatory disorders. So when I see a patient with psoriasis, I'm not automatically thinking, oh my gosh, we need to get these lipids corrected, but it turns out it's a chronic inflammatory disorder as well as rheumatoid arthritis, HIV, and others that adds to the risk. And high-risk ethnic group, South Asians are increased risk. In fact, that's been some of the work with lipoprotein a, where they had pretty good lipid panel, but they have increased lipoprotein a. But in any way, South Asia needs to be part of the ethnic groups of which we're concerned. And triglyceride persistently 175 or higher. So not necessarily real high, but persistently there. So adults with endocrine disorders have gotten some increased attention. So the Endocrine Society came out with recommending a lipid panel for the assessment of triglycerides and calculating low-density lipoprotein cholesterol for patients as a good screening panel. And with hypertriglyceride levels, in patients who have fasting triglycerides over 500, so if they're fasting over 500, then postprandially, they're going to be commonly over 800 to 1,000. So they've got these circulating chylomicrons that are potentially problematic. It's recommended to give pharmacologic treatment in addition to diet and exercise, because you want to prevent that potentially dreaded complication of pancreatitis. Hypertriglyceridemia being one of the potential etiologies for that. Conversely, when you see a patient with hypertriglyceridemia, ask him or her if you've had pancreatitis or if you're having episodes of abdominal discomfort, and it may be something that occurred without being recognized. Omega-3 fatty acids do help lower triglycerides. For adults on statins with moderately high triglycerides, and we're just talking anywhere above 150, who have either known atherosclerotic cardiovascular disease or diabetes plus 2 additional risk factors, then to consider adding icosapent ethyl, which is pure EPA. There's EPA and DHA, but this is pure EPA to reduce cardiovascular disease risk. And there are prescription brands that you can give 1 gram BID of Lavasa, Vascepa, Epanova. And if EPA is not available or accessible, then considering adding a fibrate such as fenofibrate. So trying to get those triglycerides down. Thyroid function and lipids. If your patient is hyperthyroid, that may be helping his or her lipid panel. So when you get the hyperthyroidism corrected and their euthyroid, repeat the lipids because they may not be as good as they were when the patient was hyperthyroid. Conversely, if the patient has overt hypothyroidism with TSH 10 or higher, consider treating the hyperlipidemia once the patient's euthyroid. So in other words, hypothyroidism can cause dyslipidemia, correct them, check and see if they're still dyslipidemia. If they are, then the thyroid's out of the picture and you need to treat that patient's dyslipidemia as if that patient never had a thyroid problem. Subclinical hypothyroidism. If the TSH is under 10, but the free thyroxine is normal, then the patient has subclinical hypothyroidism, and that's been associated with dyslipidemia. And there's, in the literature, back and forth discussion on whether or not you treat subclinical hypothyroidism. But if you've got dyslipidemia with it, it is a consideration to treat because it can get better. Now, the caveat with this is you don't want to make your patient factitiously hyperthyroid. So instead of giving the average replacement dose, which is about 110 micrograms or 0.1, roughly 0.1 milligram, give something like 12.5 or maybe 25 micrograms, so 0.025 milligrams a day. You're shooting for a TSH that's normal. You don't want to over replace because then there's a whole slew of potential complications, cardiovascular as well as skeletal. Polycystic ovarian syndrome and lipids. Checking fasting lipids is recommended for patients with PCOS, and that's the most common endocrine abnormality for female patients in the age range. Hypertriglyceridemia is the most common lipid abnormality. So a lot of this is sort of a pre-diabetes kind of metabolic dysfunction for many patients with PCOS. If you see a patient with low HDL, surprisingly low, there's always the possibility of steroid abuse. If you have an HDL less than 30, especially if there's not the concurrent hypertriglyceridemia, because classically, if you have low HDL, your triglycerides tend to be high, sort of a teeter-totter effect. This may be the patient with anabolic steroid abuse. Almost always in men. There are some women who do it, but in men, it's a potential concern. And superphysiologic doses of androgens will reduce HDL levels, which puts that patient at increased risk for cardiovascular disease. And that may be a motivator for the patient to stop abusing anabolic steroids. Transgender and lipids. In trans women and trans men who have had past or current gender-affirming hormone therapy, it's recommended to assess the cardiovascular risk. And there is the calculator. Now, it's not clear how to use which scale for the trans population. So a conservative approach for trans women is to use the cis male category, because basically you don't want to miss disease and you don't want to miss an opportunity to help the patient. So you want to be cautious and see if there's something that should be treated. And the calculator for trans men, it's recommended at this point to use both calculations for cis women and cis men. Use the one abnormality, the percentage of cardiovascular event that's higher, and that'll determine whether or not you treat the patient. It's said that if there's greater than a 10% cardiovascular risk, consider aspirin to prevent cardiovascular disease. And that was the U.S. Preventive Services Task Force recommendation. Now, you've got the patient recognized. You've got the patient started on treatment. How are you going to monitor? Well, it's recommended to repeat lipids 4 to 12 weeks after statin initiation or any change of dose. I like to keep things simple. I just do 8 weeks. You know, we're talking 2 months. 8 weeks, you're going to have steady state, and it's soon enough that you can go ahead and check and see if you need to make adjustments. And then repeat it, even if they're doing well, at least repeat it yearly. Certainly if clinical situation changes, you can do it sooner, but at least repeat it yearly to make sure things are as they have been. And in atherosclerotic cardiovascular disease patients at very high risk, they may need to add a non-statin drug to their maximally tolerated statin, and then you can go ahead and repeat the fasting lipid panel in 8 weeks. So, in summary, lipid abnormalities are very common, and you've seen this in your practice in the clinics. So many people have it. Just as a side note, it's been in the last 50 years, and you've seen the charts. The rate of obesity has gone up, and it's parallel with the rate of cholesterol, diabetes, and hypertension. So we're seeing it more and more. The good news is, last I heard in kids, there seems to be sort of a flattening, a plateauing of weight. So hopefully, we won't get worse and worse. Screening is very important. Lifestyle is always the cornerstone. Treatment is individualized. One size does not fit all. And that's the challenge, but it's also the fun of it, to really hone in on what this given patient needs and should have. And medication is usually well tolerated. In the old days, the lipid-lowering meds were really difficult to take. First of all, there weren't many of them, and they were, like I mentioned, they can cause GI problems. But fortunately, patients can tolerate these almost always. So Dr. Tanik put this nicely in looking at the 2018 guidelines. Hone in on these 4 groups because they're the ones that derive benefit. Those with clinical atherosclerotic cardiovascular disease, whether it's coronary artery disease, cerebrovascular, aortic aneurysms, the one we outlined. Hone in on the ones with an LDL of 190 or greater. Focus on patients with diabetes who are age 40 to 75 and LDL greater than 70. Focus on patients who have LDL 70 or more and a 10-year risk on the calculator of 7.5% or greater. So these are the 4 groups that will pretty much account for just about everyone, in which you need to roll up your sleeves and treat the patient to lower future problems. LDL levels are there to help with efficacy and adherence, and LDL can guide in terms of where we are with therapy. So in summary, continue, special lipid treatment considerations are for patients with diabetes who have retinopathy, patients with type 1 regarding their age, their disease duration, their microvascular disease, obesity, metabolic syndrome, chronic kidney disease, hypertriglyceridemia, thyroid dysfunction, polycystic ovarian syndrome, steroid abuse, and transgender. So more and more, we get an appreciation for different populations have different likelihoods of consideration for treatment. So in conclusion, atherosclerotic cardiovascular disease risk drop through lipid management. It really does work. The levels go down, and it's not just looking at labs that are better, it's looking at outcomes that have shown significant improvement. Again, cardiovascular diseases are #1 cause of mortality. And the treatment significantly improves the outcomes. Here are the resources. If you want to dive down further into the guidelines, it's there, free of charge. You don't have to be a member of the American College of Cardiology. And lipid management, similarly, there's clinical practice guidelines through the Endocrine Society. You don't have to be a member of Endocrine Society to see it. Patients can get information through American Diabetes Association, American Heart Association. Here's the risk calculator for men, for women. These are not the only place you can find it, but you can get it to see what the number is for the likelihood of an event within 10 years. And for patient education, the Endocrine Society has a Learn Your Lipids section, free of charge for patients. American Heart Association has a Move More Together. The NIH has its tobacco cessation. And there's more. The American Diabetes, like I said, has the Food Hub. And there's been some really encouraging work in plant-based nutrition. And if you have a patient who's open to the idea, here's one book, The 4-Leaf Guide. It's written by a family practice doctor and I think a nutritionist, and they basically alternate chapters for a very readable book. And there's Forks Over Knives that have they have book, they have the website, they have a documentary, and it's been shown to be very helpful. And it's not an all or nothing. It's not like a patient either goes completely vegan or not, but maybe one meal a week, try it, see. And I think, for the patient who's at all interested, it can pay dividends. Special appreciation to Dr. Feldstein, who is giving her time and kindly is moderating and had so much to do with getting this talk set up. Dr. Einstein, our Senior Director of Physician Engagement, Shirley Severe Talon, Jonathan Lewis, our IT gurus. They do so much important stuff behind the scenes. These folks put it all together. If it weren't for them, today would not happen. I mean, they do the heavy lifting and we get the easy part, and very grateful to them for that. And Dr. Feldstein will have the slide sets available for you. So with that, let me go ahead and stop sharing my screen and open it up to questions.
And with that, I'm going to stop recording for questions. Thank you. Thank you
You
so
can
much, Dr. Sadur.